Next, turn to Dr. Nicole Martinez-Martin. She holds both a JD and a PhD and is an assistant professor at Stanford University's Center for Biomedical Ethics with a secondary appointment in the Department of Psychiatry. She is conducting lots of different research, including an NIMH grant-funded study of the ethics of digital mental health technologies, and her areas of scholarship include neuroethics, digital health, bias and fairness in health technologies, and AI in healthcare. I know because I cite it all the time. She's published some of the leading work in this area, including, if you don't know it, as one of the leading pieces on the ethics of digital phenotyping in Nature Digital Medicine. And I'll just say on a personal note, if any of you attended the wildly successful and first ever virtual annual meeting, virtual meeting of the International Neuroethics Society, you can thank Dr. Martinez-Martin, who has really steered that conference. So it's great to see you again, and thank you so much for sharing your knowledge with us today. The floor is yours.
Thank you so much to Francis Shen for inviting me to be a part of this conversation, and to McLean and Dr. Jackson, just a wonderful initial presentation to start the conversation. So I know we're following a number of days of talking about these kinds of issues. Digital phenotyping, similar methods have been already discussed, and I'll just focus here on noting with digital phenotyping, a lot of the idea is that added benefit of collecting data, somewhat in the wild, with smartphones, wearables, using social media to make the assessment and predictions. There's different names that have been used for this. Personal sensing is another name that has often been used for this type of work. But as I'll be getting into, and in talking today about some of the issues of algorithmic bias and fairness in this approach, I'll note that increasingly research projects using this are embracing different levels, different types of information in their approaches. And so let's see. So starting off with, there is the different type of data that might be collected of, sensing data, social media, as well as different biometrics, increasingly genomics, as well as MRI and other types of scans have been included. This is in order to make different assessments: cognition, emotion, social functioning, and of course the idea, and it's something that's been a big part of the conversation, is the opportunities that so often that limitations on assessment of mental health is to when patients are able to visit, and so this opens up a lot of the different types of information that might be available on progression, course of someone's illness or mental health issues, what might be needed as part of those interventions. And also, while I'll be focusing on medical research applications, it is really important to note that these types of technologies, because of the way that they're able to monitor behavior, mental health, are of interest in a number of domains, and so these implications when it comes to bias and fairness can have very different impacts and additional implications depending on the domain that they're being used in. And so this goes a little further, the slide, into some of the different types of data. So you might collect facial expression, behavior traits, acoustic analyses, as well as text, as I said, genomic, brain activity, and other types of interactions can be captured in this. And I note these different types of data because of the ways that it can figure into, different needs of, who's included, what types of issues there might be in looking at whether different populations are served by this data and by the way that it's employed. So with ethics and digital phenotyping type technologies, it comes up the questions of, how different this is from other types of technologies. Genomics, obviously have a number of overlapping issues. And so I would note here that, some of the challenges come into the intersection of certain features of these types of technologies. For one thing, the large amounts of personal data that may go into these analyses, that there are a number of ways that either the collection of this data may be done outside of existing frameworks for addressing it. Privacy obviously being a big area where this is a concern, where health data has long been protected according to being generated and in health institutions with providers as gatekeepers. And now sensitive personal information can be used for behavioral health purposes outside of that, and what type of protections are available. There, with the predictive and inferential information that's involved, people may not be aware of the kinds of repercussions, the types of information that can be generated, the inferences that can be made. And particularly of relevance here, of course, is also the way that machine learning issues intersect with these various challenges, where machine learning poses challenges for regulation, where the FDA, has had to come up with new approaches based more on process, often in terms of, how the companies or researchers conduct their business, rather than sometimes scrutinizing, the algorithms themselves, as well as the need for, educating stakeholders at different levels regarding, the limitations and proper context for these types of analyses. So, with that, a number of these issues that come up can look, privacy, accountability, transparency, they, have echoes in a number of different areas of health information, and yet because of this combination of issues, they present different challenges. And of course, I'll be focusing on fairness and bias in this particular presentation. So bias, of course, can have different aspects to it. And just to note a couple facets, there are ways that algorithms can embed values, which because of the way decisions that get made, how certain data is labeled, what values to optimize in terms of outcomes. If insurance companies are involved, of course, they may value different outcomes than the patients or the doctors, or is implemented in healthcare system, the values that may be embedded in these systems that may use metrics that matter more to the healthcare systems than to the patients. As has been talked about repeatedly, the quality of the data, of course, also affects these bias concerns. Missing data, whether there's sufficient representation of diverse populations, and also very important is how the data that's used may reflect existing disparities. EHRs are being increasingly incorporated in these types of projects using digital phenotyping, and it has to be understood how the outcomes and practices in the EHRs may reflect existing healthcare disparities, how some populations may be treated differently. And, COVID, of course, has put a spotlight on the many layers of how people of different races, of different socioeconomic status receive very disparate treatment. And that has to be understood how that might be may be involved in the data that's being used as part of these projects. And of course, the importance of how some of the data may also reflect different populations and social structures, social inequities, rather than other issues that may affect the output of the algorithms. Algorithms, of course, may be not suited for use in different contexts. They have to take into account limitations when used in different contexts. And those are all things that are very important to note in these discussions of fairness and bias. There are examples that I think have already been noted many times, including just in the panel just before this, or in the discussion just before this, of the way different algorithms in the past have already been noted for having outcomes that display racial bias. The algorithm used to manage the health of populations, was just discussed in terms of how it used cost as a proxy in a way that ended up having a disparate outcome for African-American patients. And one thing that should be noted in terms of, the issue of missing data is that, there was a very small set of Black patient data that was included in that. And it was also an example where part of where the disparate outcome was able to be tracked was because of more transparency and access in terms of studying that algorithm that was given to researchers. So to look more specifically at one of the types of data that's being used in digital phenotyping, facial recognition technology has been incorporated in some digital phenotyping approaches. And some examples are using them to assess affect, emotion, for pain detection, as well as genetic diagnosis. And of course, there needs to be attention to the potential for bias in these particular areas of facial recognition technology. So there's been a lot of attention to facial recognition technology in terms of identification, not as much to these uses for emotional or behavioral assessment. But one thing, of course, is a lot of the image databases that get used as part of facial recognition technology training tend to have deficits or not as diverse populations. There was a lot of welcome attention to work done by Timnit Gebru, Joy Bwalamwini regarding facial analysis and how it may misclassify people according to race and gender. And that's where it can be important to think in terms of facial recognition technology and bias, how that also can play into these assessments of emotion. Lauren Rue, in a 2018 study where she used two common facial recognition systems for assessing emotion, she ran images of basketball players through those systems and found that they were much more likely to interpret Black men as having negative emotions. There also may be cross-cultural concerns involved as well. And these are all, as I said, as it moves, simply from identification purposes to purposes for assessing behavior, these are important things to remember. Pain assessment, there's been more attention in recent years around how there's differences in how, doctors recognize or treat pain in African-American populations or people of color. But there also need to be concerns in terms of this opportunity to perhaps use facial recognition to improve that. The basic level of simply, how different skin tones may impact these, these assessments, as well as, for other types of uses, how cultural or social context around how pain is expressed may also affect that kind of data. There are, of course, opportunities in terms of using these for improved diagnostics in, let's see, improved diagnostics, but being aware of these potentials for misuse, for how sort of historic differences, as Dr. Jackson mentioned, of disparities in how diagnostic categories may be applied to particular groups, and how that may be reflected in the data. In particular, this issue of, of separating out, how much the data is actually embedded in social social inequities, social factors, when it's well known the extent to which social factors influence things like the progression of depression or psychosis, and that makes it important to address. So in terms of addressing it, principles, of course, have been mentioned, but as a recent article by Brent Mittelstadt pointed out, principles alone are not able to guarantee ethical AI because of differences in proven methods to translate principles into practice, the AI development lacking common aims, fiduciary duties, as well as professional history and norms in this area. And that's part of this conversation, is building those, especially the use of collaborative approaches, community engagement, as Dr. Jackson mentioned, but also improving collaboration among different stakeholders and interdisciplinary teams, and providing for diversity among the researchers is part of bringing that consideration of ethics and values more centrally into the design and development of these algorithms. Thank you.